Hi, Dr. Brian Koffman, a doctor turned patient with CLL at ASH 2013, and I'm here with my friend John Pagel. John, you want to introduce yourself?
Yeah, hi. Again, great to be here with you, Brian. I'm John Pagel. I'm from Seattle. I'm at the Hutchinson Center there in the University of Washington.
So we were talking a little bit about these these antibodies that carry a radioactive package with them, and some very encouraging data that you had, but they're not used very much. And you talked about the navigation issues, but also, let's be honest, there's some economic issues and how they fit in. Tell us a little bit about the future, or what you see. I know it's speculative, but what do you see?
Well, I think it's, as everybody you sit with will tell you, this is an incredible time to be in the research field for these drugs in CLL. We have all these new drugs, many more in development in the pipeline, second generation, third generation. These are going to be new and improved drugs. So the landscape of how we're going to treat patients is totally changing. These games, as you've heard the term, truly are game changers. The problem is, I don't think we're really clear how the game will change. Where will the game change and how fast will it, and how will everything else be affected? So lots of questions arise there. One is, what will be the role for chemotherapy as we move forward? Will we be doing less chemotherapy? I think almost assuredly we will be. And where will we be doing less chemotherapy? First line setting, or just in the later relapse settings? I think that's very unclear. I think my speculative hope is that we do less chemotherapy across the board, and in particular up front in the first line treatment. Hopefully we get to this.
I'm with you there.
Yeah, and you know what this is like, right? And I'm sure if I was a patient, my own personal preference probably would be to say, I don't want chemotherapy. I want something that's going to be extremely well tolerated and targeted, and without risk of hair loss or those types of things.
It's not so much the hair loss or the throwing up, it's more the secondary myelodysplastic syndromes, the secondary cancers, the infection risks, and all of these have a significant treatment-related mortality associated with them.
And of course, those are also even more significant if you're talking about a patient who might be, in their 70s or so, which is not uncommon. So I think chemotherapy is a big deal. How we sequence these drugs is not clear. Because we don't have enough follow-up. We're just starting to see people who might fail one of these new exciting drugs, but we don't know how they're going to do when we get the next treatment. My hunch is they're going to do great. There are some anecdotal cases where we've started to see this, but it's very exciting.
Where they failed one TKI and they've been switched to another tyrosine kinase inhibitors, and they've responded nicely.
Yeah, and certainly.
And they're like one star on those plots you see, like there's one or two patients on those waterfall plots,
Yep. And then, of course, many people are talking about putting these drugs together in combinations, and that'll have to happen, but that's a little ways off. And I think the other issue that's very unclear that we need to sort out is how the financial aspects of how much these drugs are going to cost and what the impact will be to patients. But regardless of all that, it is remarkable the buzz and the importance that these drugs have created in the CLL community and here at ASH. I don't think you'll find a disease that's got more excitement in its research presented here at this meeting than CLL. As a great example, there's a late-breaking abstract that I think the data is just really out of sight.
So tell us about it.
Yeah, no, this is a great trial that I was lucky enough to participate in. Many patients we treated in Seattle, where patients were given rituximab, the standard doses that you give with CLL, but patients were randomized to get a pill, one pill or another. They were either given the pill known as idelalisib. Many people might remember that as known as GS1101, or even Cal101.
Right.
This is the drug that targets the PI3 kinase delta isoform.
Right. It's
another tyrosine kinase inhibitor. You either get that pill in combination with rituximab, or actually patients got a placebo. And we treated over 200 patients, 250 or so patients, maybe a little more even. And the plan was to follow these patients for quite a long time. The interesting thing, though, is that we built in an interim analysis at just 6 months or so to really look at and see how these patients were doing. And it was so overwhelmingly positive for the patients that were getting the idelalisib overwhelmingly positive from a standpoint of response, from a standpoint of keeping your disease away, meaning disease-free survival, and even a significant major improvement in overall survival.
So soon to get that result.
It's very impressive. People that got the idelalisib with rituximab living longer than people that got the placebo. And then, of course, I should point out, on that trial, which is very important, is anybody that got the placebo now is completely getting the idelalisib. They get a
If they progressed, yeah.
Even if they don't. Everybody at this point is all unblinded because the results were so positive and so overwhelming. Now everybody is switched over and can get the idelalisib.
So I was talking earlier today, and one of the problems that, with Jeff Sharman
Yes.
On this trial, and one of the concerns that I had, and I addressed it with Jeff, and I'm going to address it to you, is rituximab is kind of a little bit of a straw man that you're putting up there, because no, that's not true. No academic center gives rituximab. Now, a lot of community hematologists give rituximab, and I know a lot of patients personally who've had rituximab as their only therapy, but it is a pretty easy straw man to knock over in terms of comparison. So how do you respond to that?
Well, I agree with everything you've said, but the most important thing to say is that even though it is a straw man, it is what gets used in the CLL world. If you look at community oncologists, the vast majority of them are using single-agent rituximab. Whether it's a great option or not, that's what's being used. So we need to improve on that, because of that is what's in practice, and here's a great way to do it. And it's a great way to do it without chemotherapy, hopefully avoiding those secondary malignancies, febrile neutropenias, all those kinds of things. So yeah, it is a straw man, but it's an important one, as opposed to many of the states, for instance, where chlorambucil has been employed, where at least in the United States we don't use a lot of that. I consider that even a much bigger straw man.
I agree with you.
Because we don't even use chlorambucil in most cases. So that trial, I think, was an overwhelmingly positive trial. It's actually going to, I'm sure, get published in a leading journal very soon. We've submitted that for publication. And we're really excited about that drug and all of these drugs, including even one that we haven't talked about.
So let me just start adverse events with the idelalisib
It's a good point. Now remember, idelalisib's a pill, just like ibrutinib. This pill, idelalisib, you take twice a day, as opposed to ibrutinib, which, as you know, you take once a day.
Yeah.
The major adverse event that you need to be on top of and think about is that there are some people who will have diarrhea that can be significant. Probably not more than 5% of patients having what we would call grade 3-4 diarrhea, significant diarrhea, but it can happen. And in those cases, patients will typically need to stop the drug, but many of them have been re-challenged, taking the drug again once things have normalized, and they've done just fine without problems with diarrhea. But the mechanism of why people are getting diarrhea with idelalisib isn't known. And once we can figure that out, and we're looking at that closely, then we'll be able to probably sort through the way to either get around it or prophylax against diarrhea or treat it, what have you. I will say it's reversible, people respond and people end up doing just fine, but no one wants that side effect if they can avoid it. That's the major side effect. Certainly, like with any other treatments, there's risk for neutropenia and some infections or things like that, but it's usually very well tolerated.
And just briefly, in less than a minute or so, the pneumonias, there were some strange pneumonias and liver function tests. Can you just comment on those?
Well, yes, and that's, I kind of glossed over that. But the liver function tests, there are some mild elevations in the liver numbers, but they normalize, and we haven't had any liver problems from a clinical standpoint. We don't really know what to make of the liver enzyme elevation. It's something we take seriously. It happens rarely, fortunately, but it's something to watch and to pay attention to. I would say that there have been some unusual infections, some pneumonias, something that you don't see a lot. We've seen very few of these in the idelalisib trials, but we have seen them. And we need to figure out if that's unique to this drug or if that's just something that happens in this patient population. And we don't know the answer to that at this point.
So let's hold there for a minute and we'll pick up in a sec.
Great.
Thanks.